Well, hey everybody, my name's Kevin, paramedic practice educator on the island. And as we get into the summer lull with some upcoming holidays, I thought it might be nice just to shoot one more video on something that's come up a little bit in calls as sort of summer trauma season goes on. Thought it might be interesting to talk about traumatic brain injury. And in order to help us, I have enlisted the help of a wonderful, smart, talented guest, and I'm very happy that he could join us to talk about traumatic brain injury. So why don't you introduce yourself? Hi, thanks for coming. Well, hey, thank you so much for the great introduction. My name's Kevin Lambert. I'm a paramedic practice educator on Vancouver Island, almost on vacation. And yeah, it's a pleasure to be here. So thanks very much for inviting me. You're looking great. Well, thank you. I think you're looking pretty good too. So, hey, why don't you just take us through a little bit of what actually qualifies as a traumatic brain injury, and what are some of the maybe pearls and pitfalls that we can think about in actually dealing with these patients, and then maybe we can get into some pathophysiology. Oh, hey, yeah. Thanks very much for the question. That's really nice of you. So happy to talk about TBI a little bit. We're going to keep it pretty simple because a traumatic brain injury is, oddly enough, exactly what it sounds like. You get bonked in the noggin, you have an injury, it's a traumatic cause, you have a traumatic brain injury. The thing that's really important from a pre-hospital perspective that paramedics are dealing with is kind of deciding how bad that is and what's going on with it. So the classic way that a traumatic brain injury is categorized is really by, of course, the GCS, the Glasgow Coma Scale or Coma Score, depending on what you want to call it. So as we know, the GCS is divided up into eyes, verbal, and of course motor. And we get a score for each of these ones, for each of these things that ranges in total, once you add them up, from 3 to 15, 15 being normal. So a mild TBI, if you get bonked in the head and you seem okay, is anyone with a GCS of 14 or 15. So those folks may have a concussion, not saying they don't have something going on, and something that honestly can lead to a lot of downstream consequences for people with headaches and vision disturbances and problems that can sort of be somewhat long lasting. But for the intents and purposes of what we're dealing with in the pre-hospital realm, somebody with a TBI with a GCS of 14 or 15 is considered to be a mild TBI. When we get into 13 and down to 8 to 13, we're talking about a moderate TBI. And I think that that's pretty most easily reflected if we look at the breakdown of the GCS. Eyes usually range from either sort of 1 to 4. Verbal is going from 1 to 5. And then a motor score is ranging from 1 to 6. So obviously it adds up to 15. Usually when we talk about a GCS, like we said, of the mild, the 14 or 15, these are all fine. You usually lose a point for eyes maybe being closed, needing prompting to open all the time, or perhaps they're just confused, but everything else is working fine. As soon as we get into that 13 and below category, we start to usually have either sort of a deep sedative or sedation or unconscious kind of effect where people are not opening their eyes or their speech is totally incoherent or whatever it may be. Or we start to see the motor signs where people aren't obeying commands. Now we're relying on them having to either localize pain where they cross the midline and they actually try to localize a trap squeeze perhaps, or they're actually withdrawing from a specific stimulus on their fingertip. Or of course, even worse, we see them start to decorticate or decerebrate posture. So the GCS of 13 and below also ties into our major trauma guidelines where a GCS of 13 or less after a traumatic incident will be noted to be a major trauma. So it's the 13 is an interesting one too, because it used to be 13, 14, and 15 was actually considered to be a mild TBI, but there's actually been some rethinking on that. And 13 has actually been moved into the moderate category because they found that up to a third of patients with a GCS of 13 actually require some intervention and have some problems downstream, some more serious problems. The last, of course, is a serious TBI, under 8. And this is usually where we're into the motor signs for sure, where we have people posturating, they're not localizing pain, their speech is incoherent, they're unconscious. Whatever combination sort of adds up to that less than 8 factor. So that's kind of how we range it in sort of mild, moderate, and severe. You mentioned briefly the idea of do we have somebody who is, what are the pearls and pitfalls? I think the biggest pearl is make sure we're doing a solid, good motor score, because that motor score is really key. You really want to make sure that you're seeing if somebody is actually localizing, and crossing midline is a great way to see that, right? If somebody actually reaches up for that trap squeeze versus somebody who's withdrawing from pain, which should be pretty brisk. Decorticate is obviously going to the core, and decerebrate away. So always a good idea to keep that in mind. The biggest pitfall I see with a TBI and dealing with somebody, especially as we get into that actually more severe TBI where we have to do some airway intervention, or we have, maybe multiple patients, whatever badness has occurred, is that a TBI can be a very big distracting injury. And I think it's really important that people keep in mind that you might have a TBI that you have to deal with and some of the other stuff, and you're worried about the airway and providing oxygen. But don't forget that they might have a closed femur fracture that's kind of hard to find at first. And you have to be really diligent about doing that RBS and a secondary survey and make sure you're finding that, because you can be doing all you can for a TBI, but if somebody is in hypovolemic shock from another injury, you're doing no favors to their noggin, if that makes sense. So yeah, I hope that helps. Yeah, that's great. So why don't we just turn our attention to just a little bit of the pathophysiology so everyone understands the different kinds of traumatic brain injuries and what we can actually maybe do about them, or what'll be done in hospitals sort of further down the line, and why it's so important to differentiate some of these things. Hey, yeah, thanks for the question. Let's get into the patho bit, because we've kind of talked about obviously TBI, GCS at 13, or 8 or less, being severe. So let's just get into talking about the traumatic brain injuries a bit. And what I've done here is I've put a couple of images up just of the brain as you might see it if you looked at a CT scan. It's called an axial section, where you're sort of like chopping the head this way and taking a look inside. In these cases, it's actually more like you're looking up at somebody from the feet, and you're looking at a slice of their brain as you look up, which makes this the left side and this the right side. But regardless, I just thought I'd talk about some of the physiology of what's going on, just so it's clear to everybody, because different physiology gets different kind of care. And we won't know that necessarily in the pre-hospital environment, but just so you understand what's going on and why it matters and why we do what we do. So in this sort of the most basic thing here, I kind of just envisioned, like you can see there's just a little bit of red. This might be like a contusion, or somebody with a concussion, and a few small contusions, small hemorrhages right here, that you can have what's called the coup and the contra coup injury. You get bonked in the head, and then all of a sudden this part of the brain smacks against the back of the skull, and you get injuries kind of on both sides. In this case, this would be hopefully more minor with not too many symptoms, but you can still get people that have concussions and bad symptoms from having stuff like this, and they're still at risk from some damage. When we think of TBIs, though, that's a little bit, we tend to think of bleeding in the brain. That's not always necessarily the case of what's going on, but I thought I'd highlight it just so everyone's clear. In this image here, we have the skull. We have the green representing the dura, which is a thick fibrous cover, just like cap sitting on top of the brain. And in this case, we have a fracture that I drew in here. And this is meant to highlight the fact that if you get smacked in the head and you get injury, usually a fracture, you're really at risk for rupturing arteries that sit just in between the skull and right by the dura. And you can end up with what's called an epidural hematoma. Epidural, obviously, because it's outside. It's not how you spell it, because it's outside of the dura mater. What happens is you get this blood that accumulates, usually from the middle meningeal artery, which is an artery, obviously, so it has a high pressure and puts out a lot of blood. And it can start to squish that dura mater and squish the whole brain down. The issue with these is these people can present as like a GCS of 15 after something happens. Kid falls off a skateboard, smacks their head, seems okay. Maybe folks don't want to go to the hospital, or he doesn't, or whatever. Or, somebody falls down, maybe, after a couple of whiskeys or something, good whiskeys, bourbon, and falls down and smacks their head. And this can actually accumulate over, minutes to hours. So they might seem fine initially, but then, 2 or 3 hours later, they can have a big steep decline. That's why everyone needs to go to the hospital if they have a head injury, for sure, especially if they're anticoagulated, maybe intoxicated, those sorts of things. It's very important, especially like people in cells, or that have been arrested. We need to make sure that we're taking care of those folks too, because the risk of an epidural is not very good. So that's generally, like I say, an arterial bleed. So that's one type of head injury that you can have that would qualify as a TBI. It can start to affect your GCS obviously you can see it's starting to shift and actually push the brain from the amount of pressure that builds up in there. This is the kind of thing that actually, when they talk about like drilling into the skull and getting blood out, it's this epidural one where there's actually a pocket of blood. That's the one they're talking about. That being said, it's not going to happen in a lot of places because it's kind of a neurosurgical procedure. You need to know exactly where that bleeding is. You don't want to go in and cause damage to the brain. And usually, because of clotting, a small hole might not be enough to actually get rid of anything. You actually need to take parts of the brain off itself. Let's contrast that with this one here. And this one here is actually called a subdural, oddly enough, because it's on the other side of the dura. And you can see the dura is still intact here, but the blood is accumulated actually around the brain above the arachnoid, and it's starting to sort of fill in more around the brain and push the whole thing. These can happen in trauma. They can also happen chronically in the elderly, in people with, people who have alcohol use problems. Chronically, they can end up more at risk for subdurals. And people can fall. They can have chronic ones that have already clotted off, and they can get acute ones on top of that, so they can be more susceptible to a head bonk. So that's something to think about. These tend to be more venous, right? There's no hard and fast, but these tend to be more venous bleeding, both from trauma and from just normal course of living if it happens. Over here, this is a really crappy drawing, but what I'm trying to portray is that around different sections of the brain, underneath the arachnoid layer, you can actually end up with what's called subarachnoid hemorrhage. And a subarachnoid hemorrhage is one that occurs kind of more deep down in the brain. A lot of them actually happen from aneurysms. If you have an aneurysm around your circa Willis, you have a little malformation there, a little berry aneurysm, those can burst, and you tend to get blood in the subarachnoid space. You can also get it from traumatic cause, but those can be arterial, but they can also be venous. But they will look for blood sort of in between different parts of the brain on that CT scan. The last one that I put here is an intracerebral hemorrhage or an intraventricular hemorrhage, where you actually get blood within the brain tissue itself. A lot of times this can occur from hypertension and bleeds in the brain, where people have a sudden onset of a change in LOC or whatever neural finding they might have. But you can actually get bleeding going on right in the brain, so stroke mimics and stuff like that. That blood can also present right in the ventricles, which is where CSF is, and that cerebrospinal fluid is produced constantly and flows through the brain and down into the spinal cord. And when you get a bunch of blood stuck in there, what happens is it tends to clot and block that circulation of CSF, and the body keeps churning out CSF, and you can actually start to get these what's called the ventricles, where the CSF is, can get bigger and bigger and bigger and start to cause problems with pressure in the brain. So all of these can cause pressure in the brain. That's the problem. And they can also cause injury beyond just what the initial injury was. If I have an initial injury right here, but we don't treat it, and this gets worse and worse and worse, we can start to affect more and more brain around it. And that's what we want to avoid, is that sort of secondary injury. And that's why our guidelines are written like they are, to make sure we avoid bagging somebody too slow or too fast, avoid hypoxia, avoid hypotension. We want to keep that systolic blood pressure up to make sure that we're getting enough blood to the areas of the brain that we can still help. We want to check a glucose. We want to sit the head of the bed up at least 30 degrees, because that lets blood drain out of the brain in the vein. That's cool. Anyways, so we want to try to decrease that intracranial pressure by letting all that happen. Unseen, we won't know if there's actually increased ICP. We can guess. There's some signs. You can have a blow in pupil, which might suggest that there's increased intracranial pressure, that you're having a shift occurring that's affecting the optic nerve and affecting the brainstem. But we don't know for sure what that pressure is. So we take the steps we do just in case. Sit people up, avoid hypotension, with just some fluid boluses if it's appropriate in the context of the rest of the trauma. But we really need to take care of the brain. So it's a bit of a dance. And you can always reach out if you have a long transport time, get help, another crew, ACP, CCP, call the PS, whatever you need to get some help, if you need any help with the decision making about what you're doing. Yeah, so that is just a very quick jump into some of the types of TBI. There's a lot we could do. We could turn this into a whole day-long thing and have a nice session on it, but I just wanted to cover kind of some of it to give you a bit of an idea. So there we go. Reach out to your PPED if you have any other questions. Not this guy, because I'm going on the boat. So there you go. Thanks for having me. Yeah, thanks very much for all of that. I think that was just excellent. Obviously, you're brilliant. So I'd like to thank you again for coming, and I hope that you have a wonderful summer. I hope that everybody else does too, and everyone stays safe and does great things for patients. So again, thanks very much for joining, and we'll talk to you, honestly, probably after the summer's done. Have a good one. Thank you. Bye-bye.